Hello? Yeah. Good afternoon. We need to get going because we're running a little late. So everyone please find their respective seats. And they have to get our signs right so we know who we are. Let's see, I'm... Karen
Gelman.
Good afternoon. I'm Dr. Dan Hayes from the University of Michigan, and I'm pleased to co-chair this session with my good friend Karen Gelman from British Columbia, from Vancouver. And we'll get going right away. Our first speaker is Dr. Angelo Di Leo from Prato, Italy, and he'll be discussing adjuvant and neoadjuvant chemotherapy in patients with ER-positive and HER2-negative breast cancer. And we are imploring our speakers to please stick to the 20-minute rule because we're under the gun right now. Thank you, Angelo.
Thank you very much. Thanks to the organizer for the invitation. And thanks also to Amelia McCartney, who is a fellow in our institution, who has been helping me in preparing this lecture. Please take a few moments to read my conflict of interest disclosure. So actually, the topic of my talk is going to be how can we improve the magnitude of clinical benefit from neo or adjuvant chemotherapy in ER-positive, HER2-negative early breast cancer patients. I think actually if you want to improve the magnitude of the clinical benefit, you have first to know who are the patients who are going to relapse. So you have to work on prognostic factors. And then you have also to work on which are the tumors that are the most sensitive to adjuvant chemotherapy. So work on predictive factors. If you can do that, you are going definitely to improve the benefit derived from adjuvant chemotherapy in this population of ER-positive, HER2-negative breast cancer. Now, let me talk first about prognostic factors. How can we identify the patients who are going to relapse? These are well-known data coming from two important studies run in the past, looking at the use of Oncotype Dx in ER-positive, HER2-negative early breast cancer patients. And in this slide, I'm focusing specifically on patients with the so-called high-risk score by Oncotype Dx. You see node-negative and node-positive patients from two different trials, and I would like to draw your attention on patients from these two randomized trials who received just tamoxifen. When you look at these Kaplan-Meier curves, you see that a substantial proportion of patients with high-risk score by Oncotype Dx receiving tamoxifen alone are doing quite well, because you see that in the node-negative study, about 60% of them are event-free, and in the node-positive trial, about 40% of them are event-free. What does it mean? Does it mean that tamoxifen is doing well in this particular group of patients? It may be, but I'm not entirely sure about that. My guess would be that these patients are event-free mainly because they have been most likely cured by local therapy. So this analysis, in my opinion, may suggest that we are overestimating the risk of disease relapse. Let me move to another study that has been reported more recently, the well-known MINDACT trial. As you know, in MINDACT, another genomic tool, the so-called Mammaprint, has been compared to the standard prognostic factors. And I don't want to go so much into the details of the study results, but I just want to draw your attention on the red curve of this graphic, where you can see patients who were high risk by clinical and by genomic criteria. This accounts to approximately 1,800 patients. When you look at the red curve here, you can see that these truly high-risk patients are disease-free, distant disease-free at 5 years. In the vast majority of cases, almost 91% of patients high risk by clinical and by genomic criteria are distant disease-free at 5 years. Of course, most, if not all, of these patients received adjuvant chemotherapy, but, however, I would argue that it's not possible that the 91% distant disease-free is only due to adjuvant chemotherapy. Again, I would suspect that some of these patients, despite the fact that they've been defined high score by clinical and genomic criteria, they have probably been cured by local therapy alone. So another potential example of overestimating the risk of disease relapse. Why might we overestimate the risk of disease relapse? Think for one moment to all the research that has been done so far in the area of prognosis of breast cancer. What we are doing today is that we are looking at the primary tumor, and based on what we see in the primary tumor, we assume the presence of micrometastasis. That is fine, but in the last few years, we have seen that in the near future, we might change our strategy because we might detect the presence of micrometastasis instead of assuming the presence. And potentially, this strategy might be very fruitful in terms of better estimating prognosis. Let me give you a few examples of how in the future we could detect instead of assume the presence of micromets. This is a well-known study run by our German colleagues, reported in the Journal National Cancer Institute a few years ago, looking at circulating tumor cells. And you can see that this population has been split into different cohorts, one with the CTC negative sample, blood sample, assessed after breast cancer surgery, and the other cohort with a CTC positive blood sample, again, evaluated a few weeks after breast cancer surgery using the so-called CellSearch technology. In this slide, you see the analysis where there is a quite conservative threshold for defining the sample as a CTC positive, at least 5 CTC in the blood sample. This accounts for approximately 3% of the study population. And when you look at the results, it looks like that the CTC positive population is doing worse than the CTC negative. Now, of course, we may argue that perhaps we may have in the future more sensitive technologies to detect CTC. I'm not going to say that this is going to be the standard of care. I'm just going to say that this is a nice proof of principle that detecting micromets instead of assuming the presence of micromets might be clinically helpful in the future. Another nice example comes from this well-known study presented by our colleagues at the Marsden in London. Pilot study where actually they started with the biopsy of the primary tumor. They sequenced the tumor, they identified mutations in that specific tumor, and then they collected sequential samples of plasma after surgery and during the follow-up phase. And in the plasma, they were looking for the specific mutations found in the primary tumor sample. Interestingly, they found that when the samples, the plasma samples collected postoperatively were repeatedly ctDNA negative, so no mutations, the prognosis was excellent. While when they found a ctDNA positive sample, the prognosis was quite bad, as you can see here. So this is another, I think, nice example of detecting instead of assuming the presence of micromets. Again, exploratory analysis, not certainly practice changing, but I'm pretty sure we'll see more data in this field, and we are awaiting for this new data that will come. This is another potential approach to detect instead of assume the presence of micromets. This is a study that has been done in Prato by Matteo Benelli and his team from the bioinformatics unit. Actually, they started with the evaluation of the TCGA data set, And in this data set, they were looking for genomic alterations across different tumor types and also DNA methylation alterations. I will not go into the details of the study. I just want to draw your attention on the fact that the bottom line message of the study was that DNA methylations, alterations, can occur more frequently than genomic alterations across the different tumor types. So apparently, looking at DNA methylation alterations in ctDNA could be a more sensitive technology than looking at gene mutations on ctDNA. And of course, this has to be proven in the context of a specific trial for early breast cancer patients. The other interesting information coming from this work is that some DNA methylation alterations seem to be less dependent on breast cancer subtypes than gene mutations that, as we know, may be dependent on breast cancer subtypes. So potentially, looking in the future at DNA methylation alterations on ctDNA might become an interesting and particularly more sensitive technology than looking at ctDNA mutations in the attempt to detect the presence of micrometastases. Finally, another example of detecting instead of assuming the presence of micromets is represented by metabolomics as a tool that can allow you to detect hundreds of metabolites from the serum of early breast cancer patients. This is a study we did many years ago, looking at the metabolomic profile of early and of advanced breast cancer patients. And as you can see here from this slide, the metabolomic profile of early and of advanced breast cancer patients looks quite different. Afterwards, other groups confirmed this finding and reported their results. Interestingly, what you can see here is that some patients with early breast cancer, when you look at the metabolomic profile, are misclassified, are wrongly classified as metastatic breast cancer patients. We raised the hypothesis that this misclassification of early breast cancer patients was due to the fact that actually they were carrying a metabolomic profile very close to the metabolomic profile of metastatic breast cancer patients, and because of that, they were perhaps associated with an increased risk of disease relapse. So we created the so-called metabolomic risk. What is the metabolomic risk? Is a risk that is assessed looking at the degree of similarities in the metabolomic profile between an early breast cancer patient and advanced breast cancer patients. So we then had the opportunity to look at the metabolomic profile of early breast cancer patients treated at the Memorial Sloan Kettering in New York, thanks to a nice collaboration we have with the breast medicine unit, particularly with Monica Fournier. And we did this study. We received the clinical data from patients treated at Memorial. We analyzed it on serum samples drawn after breast cancer surgery, the metabolomic profile. We classified the patients in these two cohorts, and as you can see, the outcome seems to be quite different. However, all this information is interesting, but is clearly exploratory. And I think we should now think to a next step. And the next step, in my opinion, is to run prospectively designed studies where we will integrate standard pathology and genomics assessed on the primary tumor with tools detecting signals of active micrometastatic disease. It can be blood, it can be serum, it can be plasma. I think that this is exactly what we should do in the next future in the attempt to produce a better prognostic stratification of early breast cancer patients. I do not think that we can certainly avoid getting the information from the primary tumor. I think that the information from the primary tumor is still very relevant, but probably in the future will have to be complemented with the information coming from the peripheral compartment. This is an example of this approach, is the MOD trial that we are running in my institution in collaboration with the breast unit of the University of Pisa. I will not go into the details of the design of the study, but the bottom line message is here that we are aiming to stratify apparently homogeneous patients, because they are all luminal B-like tumors, by using a metabolomic signature. Last part of my talk, last few minutes, we have been talking about prognostic factors, how we can improve prognosis. What's about fine-tuning sensitivity to adjuvant chemotherapy? That is the other strategy that we may have to improve clinical benefit from adjuvant chemotherapy. And of course, here I have to present the results of the TAILORx trial, particularly for the intermediate risk score group, that, as you know, were presented at the plenary session of ASCO last year and reported also in the New England Journal of Medicine. In this study, ER-positive HER2-negative patients, pre or post-menopausal, with a recurrence score by Oncotype Dx ranging between 11 and 25, were randomized to endocrine therapy or combination of chemo and endocrine. The primary study endpoint was to demonstrate the non-inferiority of the endocrine therapy versus the combination arm. And when you see here the primary endpoint results, invasive disease-free survival, the curves are perfectly overlapping, showing basically no benefit from adjuvant chemotherapy in this particular group and the non-inferiority of the endocrine therapy approach. I would like to spend a few minutes on how do we define invasive disease-free survival. I think that's an important point. Invasive disease-free survival is a parameter that is frequently used in adjuvant therapy trials, and this is a parameter that takes into account different types of events: distant, ipsilateral, locoregional, or contralateral, other primaries, death without recurrences. So as you can see, is an endpoint that takes into account different types of events. In the TAILORx trial, we had 836 events defined as IDFS events. When you see the distribution of these events between the different categories, you see that the vast majority of events were events that cannot be prevented by adjuvant chemotherapy. We do not give adjuvant chemotherapy to prevent contralateral breast cancer or to prevent other primaries. So the question is, if you look here at the distribution of events, those which are clearly preventable by adjuvant chemotherapy, the distant recurrences, occurred in approximately a quarter of the total events. So the question is, how much we lose in terms of sensitivity in this trial if we consider only the distant recurrence events as the main events that should be prevented by chemotherapy. And of course, we lose something in terms of statistical power to demonstrate the non-inferiority of endocrine therapy versus the combination arm, because as it has been shown in the slide, the vast majority of events cannot be actually prevented by adjuvant chemotherapy. If you focus specifically on those events for which you usually give chemotherapy, you see here that actually results do not change. The curves are perfectly overlapping. But again, the question that is on the table is, what could be the result of the study if we had more than 200 distant recurrence events? And we cannot answer the question because this is the study and these are the results of the trial. Another analysis that I would like to discuss very briefly is the premenopausal patients and benefit from adjuvant chemotherapy in the context of TAILORx. Again, you see here that in premenopausal patients, the combination therapy may potentially be better, but only if the recurrence score is 16 up to 25. The question about the results of this analysis are reported on this slide. This was an unplanned and therefore exploratory analysis. The proportion of patients from the endocrine therapy arm receiving ovarian function suppression that today is considered the sort of standard of care in this particular group of intermediate risk patients is only 15%. And so there is the question that perhaps in this study, chemotherapy was working as an ovarian function suppressive treatment. And this is a question that cannot be addressed in the study because no amenorrhea data following adjuvant chemotherapy were collected. So in summary, what can we learn from the TAILORx trial for our Monday morning clinical practice? On average, there is a modest benefit, if any, from adjuvant chemo in this population with a recurrence score 11 to 25. However, I think we need some caution in the interpretation of the study results because invasive disease-free survival does not appear to be the appropriate endpoint in adjuvant therapy trials. And at this particular regard, I would like to invite you to read the commentary that has been recently published by our English colleagues in the JCO, and only 15% of premenopausal patients received ovarian function suppression treatment in the endocrine therapy arm. So basically, I think that despite the intensive efforts that were done in the TAILORx trial, there is still some uncertainty and there is still some justification for flexibility when we are dealing with our patients. I don't think we can make strong statements based on the results of this study, mainly because of the caveats that I have been presenting. My very last slide, I just would like to thank my colleagues from my institution, the organizations which are funding our program, and of course, all of you for your attention. Thank you very much. Thanks.
We have time for a couple of questions, if there are any. Professor Gelber.
Gelber. Thanks very much. One comment on the TAILORx data with the hypothesis of the endocrine effects of the chemotherapy.
Yes.
And an analysis that could help would be one looking at the 16 to 25 group by RS, and then doing the spline analysis or a step analysis according to age. And if a lot of the effect is endocrine related, you'd expect the youngest to have no benefit, benefit seen in the 40-year-olds, maybe extending to 52, and then the older, no benefit again. So I wonder if we could see that analysis. That would be very helpful.
I thank you very much for this comment, because actually with Giuseppe Curigliano and Meredith Regan, we wrote a letter to the New England Journal of Medicine asking exactly for this analysis. Unfortunately, the letter has been rejected, but I think this is a very good opportunity to stimulate the TAILORx investigators that they should do this type of analysis. I fully agree. I think despite it would not prove anything in a formal way, but it would definitely bring some data in favor of the ovarian function suppressive action of adjuvant chemotherapy.
Yeah, at least as a component of the
yes,
effect.
For sure.
I see no other questions. Angelo, thank you.
Thank you very much.